today's lecture. It is my great honor to introduce our distinguished speaker for today's event. Today, we are honored to have Professor Geert Biessels share his profound knowledge and experience with us. Professor is a neurologist at UMC Utrecht Brain Center, the Netherlands. He obtained his PhD in 1997 and registered as a neurologist in 2004. And he was appointed as a chair of cerebrovascular disease and cognition in 2012. His area of expertise is vascular cognitive impairment, VCI, and small vessel diseases, focusing on novel imaging biomarkers that can help to improve diagnosis and prognostication and identify targets to personalized treatment. He is actively involved in several national and international VCI and SVD research networks, including STRIVE and HARNESS. He leads the Dutch Heart-Brain Connection Consortium and initiated the international Meta VCI Map Consortium. He was PI in 2 large RCTs in diabetes with cognitive outcomes. He participated in H2020 program, SBDs at targets and recognized. He has mentored over 40 PhD students and has over 400 peer-reviewed publications. He is a Dutch National Research Council Vidi and Vici laureate. He was appointed Fellow of the Royal College of Physicians in Nijmegen in 2016 and received the Senior Investigator Award of the European Stroke Organization in 2015. And please join me in warmly welcome of Professor Biessels.
Thank you so much, Dr. Chen, and thank you also, Dr. Hu Xiaoyong, for the invitation to attend your meeting, and it's a pleasure to join you today. So these are my disclosures. Before I start, I would like to briefly show you where I'm from. So this is the city of Utrecht, and it was founded by the Romans on a small river in the Netherlands at the northern boundary of the Roman Empire. And here at the back of the Dome Church is where the Roman fortress used to be. And then it has been, after the Romans left, a very sleepy little town in the mud with little huts, nothing special. And then from the Middle Ages, it emerged again as a city of culture and education with an old university. And the university now moved all the way to the back. So here is where the university is. But compared to Taipei and other big Taiwanese cities, it's really, really small. And this time I join you online, but it was my pleasure to actually visit your country only 4 months ago, and I have very fond recollections of joining the meeting of the Taiwanese Neurological Society and visiting your beautiful country. So I will start this presentation with sharing my take-home messages with you. And the most important message is that we really need an etiological diagnosis of dementia because it opens the way to personalized disease-modifying treatment. And this etiological diagnosis is clearly on the move. We are changing from syndromal diagnosis to biological-based diagnosis, from single etiologies to detecting multifactorial etiologies, and our way of thinking about these etiologies is shifting from deterministic to probabilistic, and biomarkers play a key role in all of this, And I will take you through these different concepts and developments step by step. So the outline of my presentation is that I will first briefly give an historical perspective on the etiological diagnosis of dementia, and then review with you developments in biomarker-supported diagnosis, addressing lessons learned and new developments, particularly in the field of Alzheimer's disease, but also in the field of vascular cognitive impairment, which is my primary area of expertise. So with regard to the historical perspective, this is how neurology was initiated, based. This is the traditional neurological approach, and this is a painting of Charcot teaching at the famous La Salpêtrière hospital, and this is the basis of syndromal diagnosis, where based on the constellation of symptoms in a living patient, we assign a diagnosis that we know should be present, but can often only be confirmed after death if the brain or the nerves of a patient could be examined. And a syndrome refers to symptoms running together. So it combines the Greek roots word running and together. So things that come together suggest the presence of a certain disease or an increased chance of developing the disease. So that's the definition of a syndrome, as you know. And the initial diagnosis that was ultimately termed Alzheimer's disease was based on observations from Alois Alzheimer's over 100 years ago in a woman, a relatively young woman, Auguste Day, who had progressive dementia with episodic memory deficit as a central feature. And Dr. Alzheimer discovered that the neuropathology of this clinical syndrome was characterized by the accumulation of plaques and tangles in the brain. And syndromal diagnoses have long been the hallmark in the Alzheimer's disease field. So these are the McCann criteria, already 40 years old, still very much used in clinical practice. And I will not go through all the different steps here, but the essence is that you establish a clinical syndrome that is compatible with a clinical phenotype of Alzheimer's disease, and you rule out other causes. But actually, this ruling out of other causes is quite shaky. So we assume often that no other causes are present, but this may be wrong. And the same for vascular dementia. So we have a checklist where we establish the clinical syndrome, we show the presence of vascular pathology, and we assume no other causes. So this is the traditional syndromal approach. And it is often correct. So syndromal diagnosis is often correct because it is a syndrome. This is how syndromes have been devised. Constellations of symptoms that point to a certain etiology. But it's sometimes also wrong. And this is also because it's a syndromal diagnosis. You don't actually prove the pathology that you assume to be there, that it's present. And this is an example when you compare a syndromal diagnosis of Alzheimer's disease or vascular dementia to a biomarker present of amyloid pathology. So in blue, you see people who have had a syndromal diagnosis of Alzheimer's disease, and the curve separates people by age at diagnosis. And you see that people who get a syndromal diagnosis of Alzheimer's disease around the age of 50, then the diagnosis is almost always right. So as you know, of course, Alzheimer's disease is extremely rare at young ages, but if doctors assign a syndromal diagnosis of Alzheimer's disease at a young age, it's almost always right. still sometimes wrong. If you look at the age when Alzheimer's disease is actually very common, you see that approximately 1 in 6 to 1 in 5 people who have been assigned a clinical diagnosis, a syndromal diagnosis of Alzheimer's disease, actually don't have biomarker evidence of Alzheimer pathology in the brain. Vice versa, the syndromal diagnostic criteria of vascular dementia actually stipulate that you can only assign this diagnosis if there is no indication of presence of Alzheimer pathology. And you see that in relatively young people with a diagnosis of vascular dementia, rarely you find presence of Alzheimer pathology in the brain. But in the 80s and 90s, 1 in 3 or even more people who have been assigned a diagnosis of vascular dementia, assuming absence of Alzheimer's pathology, do have Alzheimer pathology in the brain. So these are examples, particularly here, clearly of mixed pathology. So this syndromal approach, as I indicated, is not 100% accurate, and that has led to developments in the Alzheimer's field. So you are aware of all the efforts to develop immune-based therapies to remove amyloid from the brain, and the early efforts on this already stem from 20 years ago. And this was one of the earliest trials. And once people who participated in the trial died, it became evident that not all of them in the placebo group, but also in the active group, actually had evidence of Alzheimer pathology in the brain. So people had been included in the trial based on clinical criteria, on syndromal criteria, but didn't have the pathology present that was targeted by the treatment. And the question clearly arose, how can treatment be effective if the target is not present? And how can you justify treatment risks, exposing people to treatment who actually don't have the targeted disease? So this is the basis of a development that has been following from there to come to a more biological definition of Alzheimer's disease using biomarkers. And the basic principle of this approach is that the assumption is that Alzheimer's disease is a disease defined by plaques and tangles as the central pathology. And the second point is that, like I said, a syndrome is not an etiology, but is the clinical consequence of one or more diseases, and disease-modifying treatments engage biologically defined targets, not a syndrome, like I showed on the previous slide. So a framework that can be used for intervention trials should be based on biology, not on syndromes. And then they devised the probably well known to you ATN biomarker grouping system, where you have A and T as the hallmarks of Alzheimer biology, and neurodegeneration as a downstream consequence, which is again in a way a syndromal part of the definition, because while A and T in combination are specific to AD, the measures of neurodegeneration that are used can also occur due to other causes, but they are an essential part of the framework, because here you now show that the person has the proteinopathy characterized as Alzheimer's disease, and here with the N you show that it definitely impacts the brain. So there have been all kind of modeling, and this is also very familiar, I guess, to many of you, where the idea initially posed by Jack is that you have a sequential process where you first get accumulation of amyloid, then tau, then your brain shows signs of degeneration, and then subsequently you get clinical deficits. And this is biomarker use in practice, also in the patients with a very rare form of Alzheimer's disease, because these are people with monogenic Alzheimer's disease from the Diane framework, where you can actually know, because their family members had developed Alzheimer's disease, you can actually know at which age you would expect them to develop Alzheimer's disease. And these people have been participating in longitudinal studies well before their estimated age of onset of Alzheimer's disease, and from them trajectories of biomarkers have been collected in real life. So you see that amyloid in these people starts to deviate from control levels. The controls are in blue, some 15 to 20 years before the onset of symptoms. Tau follows, and neurodegeneration is also manifest 5 to 10 years before onset of symptoms, but later than the A and T. So very much confirming the model that I showed in the previous slide. But there are actually issues with the ATN model. And one of the important issues is that it appears that taking away the A by amyloid modifying treatment does not appear to be sufficient to halt the disease. And this was seen already in the initial study that I already shared with you briefly, where in some of the people who had received active treatment, the brain was really cleared from amyloid plaques. But despite this, the treated group and the placebo group had a similar rate of cognitive decline. And at that time, this was attributed to the fact that the people involved had a relatively late Alzheimer's disease, were advanced in their disease, and the idea was that the treatment was too late. And there have also been, of course, many developments in the immunization as such to reduce side effects. And further efforts showed that you could be successful with treatments, and this is with aducanumab, placebo versus different doses of the compound, where you see that the amyloid PET scan loses the Alzheimer's signature. And actually here some benefit on cognition was observed. And we have seen more of these trials. So these are trials from earlier this year, lecanemab, that reduced markers of amyloid, also improved or led to less decline in cognition after 18 months, but again at the cost of adverse events. And here another trial in pre-symptomatic people with solanezumab that was negative. So the promise of amyloid as a single switch to turn to halt the disease is not fulfilled. So there is a clear signal in amyloid modifying treatment, but it's not the panacea, it's not the single solution to the problem. So one of the points is that people in their brains often have more than just A and T to cause their dementia syndrome. And this is an example of that. If you have 30 people, and this is work from Julie Schneider's group in Chicago, if you have 30 people who had a syndromal diagnosis of probable Alzheimer's disease in life, you would find at autopsy that 5 out of 30 do not have Alzheimer's pathology, like what I showed you with the PET scan before. You will find that only 1 in 30 has Alzheimer's disease pathology as a single pathology that is causative to dementia. So 29 out of 30, and these are of course older people because they came to autopsy. So 29 out of 30 have additional pathologies. Out of those people, 26 out of 30 have vascular pathology in addition to their Alzheimer's pathology, and 2 out of 30 only have vascular pathology. So I show this slide to emphasize the importance of mixed pathologies, and particularly vascular pathology as a co-occurring pathology together with Alzheimer's disease. And clearly, if you have multiple pathologies and you treat only a single pathology, this may be insufficient. And this is another example, also from Julie Schneider's group, showing the interaction of pathologies on the clinical phenotype. This is from the NUN study where people were examined repeatedly with cognitive testing in the years prior to their death, and then all of them had autopsy. And what you see here on the x-axis is a summary measure of Alzheimer's pathology. And take, for example, people with a summary measure of 1. If you have this burden of Alzheimer's pathology, the likelihood of being demented at the time of death is around 45%. Now, what this image shows is that for every additional vascular pathology that you have, the likelihood of being demented at the time of death increases. So clearly, mixed pathologies matter because combined pathologies convey a higher risk of dementia than having Alzheimer's pathology alone. A further point is development of thinking in terms of deterministic or probabilistic etiologies. So this initial model of Jack is highly, deterministic. The concept is that if you get Alzheimer's pathology in the brain in the form of amyloid, you will get tau if you wait long enough. You will get neuronal injury if you have sufficient time to live, and then you will develop dementia. And this may not be 100% correct, because not everybody with amyloid does develop dementia. And I really like this paper that appeared last year in Nature Reviews Neuroscience from Giovanni Frisoni, together with many other smart people in the field, introducing a probabilistic model. And I will take you through this model step by step. This first example is about people with autosomal dominant AD. And here, this is really a strong predetermining factor to develop Alzheimer's pathology and dementia. So people with this mutation will get amyloid pathology in the brain, all of them. They will, if they live to midlife, get tau pathology in the brain. They will get neurodegeneration, and almost, but not every one of them, will develop dementia, because there are examples of rare exceptions of people who have all of this with the predetermining gene, but don't become demented, possibly due to protective factors. So here the probabilistic model starts to emerge. So despite the fact that it appears to be that you are determined to get the disease, some people still do not get this. So this is are the so-called stochastic factors. This effect is much stronger in, for example, ApoE4 related sporadic Alzheimer's disease. Many people with ApoE4 genes will get amyloid deposition in their brain. In fact, this happens in the majority. The majority also will get tau and neurodegeneration, but not everybody with ApoE4 gene will get the Alzheimer's disease clinical phenotype, even if they have the pathology. So here the stochastic probabilistic aspect becomes stronger, and this is even more strong in people with ApoE4 unrelated sporadic Alzheimer's disease, where the chances of developing amyloid are smaller. Fewer people will get tau, neurodegeneration, and even with these pathologies, a substantial set of people may remain unaffected clinically. So apparently, these ATN are very important in developing dementia, but they are not a predefined fate, and other factors co-determine the dementia clinical phenotype. And these insights emerge from the treatment studies. The whole field of Alzheimer's disease that has been very much geared towards amyloid modifying treatment now realizes that other factors are important, and you see reviews emerging like this one from Geert in Lancet Neurology this month, where they state that multiple brain pathological changes like inflammation, but also host factors like resilience, so protection against pathology, might be involved in contributing to the development of dementia. This variability suggests that the benefits of lowering amyloid beta might depend on how strongly an amyloid pathway is manifest. So that's the probabilistic thinking in an individual in relation to other coexisting pathophysiological processes. So that's the mixed pathology. A new approach to research and treatment, which fully considers the multiple factors that drive cognitive decline, is necessary. So if you accept this, you also realize that the ATN is not sufficient anymore to define the disease. And this is another editorial from the Lancet Neurology from last year that states in the same context. So biomarkers are needed to identify non-AD pathologies, alpha-synuclein, TDP-43 proteinopathies, but also processes within the Alzheimer's disease pathway, particularly neuroinflammation. So you see that with regard to biomarkers, the Alzheimer's field is tilting in a way, and that's very interesting. So in the next part of my talk, I will switch to vascular cognitive impairment. When this framework of ATN appeared in 2018, some people in the vascular dementia field were quite upset and said, where is the V? We all know that vascular dementia or vascular disease is important. Why not V in this framework? And I think it makes sense not to have V in, because this is a biological definition of Alzheimer's pathology, but anyway, it generated a lot of fuss. But if you take a step back and you were invited to actually add a V to the model, the question is what you would have put in. Would you look at perfusion? Would you look at white matter hypertensives or lacunes? Would you use diffusion MRI? And so the question arises, how should we actually define the vascular burden in dementia? And there are, of course, a clear diagnostic criteria for vascular cognitive impairment. And the essence of this criteria is that there should be presence of acquired cognitive impairment, and vascular disease should be a likely cause. But if we take a step back again, this is a scan of a young woman who had a carotid dissection, had an infarct, and had cognitive deficits thereafter. This is a 78-year-old gentleman with white matter hypertension and lacunes with cognitive slowing who has vascular cognitive impairment. And this is a 50-year-old man who had a subarachnoid hemorrhage and had permanent cognitive deficits. This all qualifies as vascular cognitive impairment, but there are clearly fundamental differences in the etiology and biology of these diseases, in what the treatment should be, and in the prognosis. So VCI is really not an extremely useful concept from a biological or a therapeutic or prognostic point of view, because it's really a very much a mixed bag. So actually, I think that the vascular field, myself included, should take this ATN framework as an incentive to take a look in the mirror and say, how can we come towards biological definitions of VCI? Because this is how we treat VCI in current practice. We have vascular risk factors. We know vascular disease processes like CAA, arteriolosclerosis. We can see the tissue injury on the scan, and we can assess cognition. And in practice, we receive diagnostic info of these risk factors. We can see the injury, and we can assess cognition. And to assess the injury, we can use standardized scales, standardized definition, and these are the updated STRIVE criteria that show the different manifestations of particularly small vessel disease on MRI, and provide you with definitions how to describe these lesions and how to assess them on different sequences. But there are issues with this, because actually, if we look at the pattern of tissue injury and we try to derive the underlying vascular disease process from that, this relation is shaky, even with relatively well-defined types of small vessel disease, such as cerebral amyloid angiopathy. We cannot always be 100% sure about presence or absence of this vascular disease process based on the pattern of injury alone. And the same is true for the relation with cognition. If we look at the amount of lesions that we see on the scan, it's not always well correlated with the cognitive phenotype of the patient. So we have to make assumptions in the diagnostic process, what kind of disease process is present, and to which extent what we see on the scan explains the phenotype of the patient. And our treatment is actually limited to treating risk factors, not the biology of the disease. We do not have really disease-modifying treatments in small vessel disease, and we can have some symptomatic treatment for the cognitive deficits. So here is really room for improvement. And this is what we are trying to do in our research program in Utrecht. We try to develop new biomarkers that move towards the core of the disease process, towards the small vessels themselves, instead of looking at the downstream injury. And others in the field are working hard to get more grips with the genes and proteins involved. On the other hand, we also try to move towards the other side and try to extract better biomarkers that are more strongly related to cognition. And such biomarkers with more functional impact are, for example, diffusion MRI that you can use to identify brain tracts, identify or quantify the condition of the brain network, but also more simple and quite robust measures like PSMD, which is actually a form of diffusion MRI where we look at the diffusion signal in the core part of the framework of the white matter. And here in this white matter framework or skeleton, you can look at the variation in the diffusion signal. And the idea is that if the white matter is damaged by small vessel disease, you get more variation in the signal like you see here. So small variation means homogeneous intact white matter. large variation means lesioned white matter. And actually this PSMD relates quite strongly to cognition, in this example in people with CADASIL, but also in people with sporadic disease, much more so than measures like atrophy or white matter hyperintensities, for example. So the other measures are related to vascular function, and this is something novel. So we know from the field of biology and neuroscience much more than we did before on the small vessel anatomy, particularly also function, the relevance of blood-brain barrier integrity, the importance of perivascular spaces in brain amyloid clearance, but also other waste products. We know about the biology of the tiny vessels as they pass the cortex, the importance of different cell types involved, and the importance of neurovascular coupling in supplying the brain with nutrients related to brain activity. And with new techniques, with 7-tester MRI, we are actually starting to probe these vessels, so we can depict the smaller perforating arteries in the brain, and we can actually start to appreciate the function of these vessels. So this is recent work from my group where we used 7-tester MRI to measure flow in the tiny perforators as they pass through the centrum senior valley or in the basal ganglia. So here you can see in the green dots are perivascular spaces that contain these vessels, and we can detect a flow signal in individual vessels across the cardiac cycle. So you can measure the average amount of flow across this cycle, but you can also look at positivity of flow, an indicator of vascular stiffness. So these measures give an indication of perforating artery function and stiffness. And we have been examining this together with our colleagues from Munich in patients with CADASIL and controls, and it proves that blood flow in these tiny vessels is indeed lower in people with small vessel disease than it is in controls. So here you really see small vessel disease for the first time at the level of the small vessels themselves. Perivascular spaces are attracting a lot of attention, and here you see a zoomed in image of perivascular space in the basal ganglia, also with 7-tester MRI, earlier study, where you see that these perivascular spaces are actually in the basal ganglia, not a straight tube, but almost a string of pearls on the T2, even more clearly on the T1. And here you appreciate the artery that is running inside this perivascular space. So really we are zooming in on these structures, and you can start quantifying these perivascular spaces. On 7T you see many more than on regular field strength, and you can look at their tuberosity, density, and derive metrics from that. This is work from one of your colleagues, Yongnam Xu, from Taiwan, who uses a diffusion tensor-based method to estimate the condition of the perivascular spaces, and found that the perivascular space condition appears to mediate the relation between, for example, amyloid and tau accumulation and cognition. So this is really a rapidly evolving field. This is another example of novel biomarkers. The idea is that fluid flow in the perivascular spaces is driven by the pulsation of the heart. So the pulsation of the tissue squeezes the fluid through these perivascular spaces. And we have been working in 7T on sequences to actually measure this pulsation at the voxel level in the brain. So here you see images of voxels that expand or compress along the cardiac cycle, and you can see how equal the compression is across a voxel. So some voxels compress really evenly, and others are stretched in a way. So we are in the process of further developing this technique, showing which areas of the brain are particularly compressed and which are expanded across the cardiac cycle, and the pattern to which these voxels deform, and possibly these techniques can be used to calculate the drivers of this brain clearance. Other techniques relate to blood-brain barrier integrity. We can start depicting the draining veins, cerebral vascular reactivity, and neurovascular coupling can be assessed with functional MRI as a final example. So functional fMRI is often used to look which areas of the brain are activated with a certain task or stimulus, but you can actually also use it to really quantify the neurovascular response that is at the basis of the so-called BOLT signal that is used for fMRI. So here we used the visual stimulus and did a very high spatial and temporal resolution fMRI experiment where we could really look at the time characteristics of the BOLT response with high temporal resolution, and therefore you get a high, very precise estimate of this response if you give a very brief visual stimulus. So this is what we did in people with CADASIL again, and in controls. So this is the experiment in people with CADASIL with a brief stimulus, where you see that the amplitude of this short response is lower in people with CADASIL. We also have the similar experiment in people with sporadic small vessel disease, and there, interestingly, you see a different response where the amplitude is not so much significantly lower, but the response is shorter. So the temporal dynamics of this response appear to differ in people with small vessel disease. So apparently, if the vessels are affected, they cannot respond as efficiently as healthy vessels. So we are zooming in at these vessels, but this is still early stages, but there's rapid development, and we see emerging patterns of differential vessel involvement in different small vessel diseases. And I don't think that this will be the next diagnostic test, but I think that these measures of small vessel disease at the level of the small vessels will help us to understand the disease and possibly test new treatments. Clearly, this needs to be complemented by studies finding the molecular targets that drive all of this. So there's a lot of development in the field of genetics of small vessel disease. For example, work of Stephanie de Bette, identifying many genes that define proteins that may be highly relevant for small vessel function. So getting back to the ATN framework and the question, where's the V? You may be aware that the ATN framework is being revised at present. Actually, the group has updated the model to address core Alzheimer biomarkers. So these are typically the A and T, and then non-specific biomarkers that are important in AD pathogenesis but are involved in other neurodegenerative diseases. So that would be the N. But then they add biomarkers of common non-AD co-pathologies. So here the V does enter the model, and this is a table from the draft new paper where you see that vascular brain injury is present. but they only look at imaging at present, and they have not identified specific fluid markers yet. So this is in development. If you wish, you can look up the paper on the Alzheimer Association site, and you can still provide your feedback to this new model up till next week. So wrapping up, I've tried to show you that the etiological diagnosis of dementia is really on the move, that we are moving from syndromal to biological diagnosis, and this is essential if we want to provide treatment. There's better appreciation of the multifactorial etiology, and that we should assess all of these etiologies, and our thinking about these pathologies is moving towards more probabilistic models where you have to weigh and balance all the different adverse but also protective factors of an individual, and biomarkers are key to these developments. So you can envision a future where a biomarker framework for dementia would look like this, where you have predisposing factors with causative genes, risk genes, demographics, lifestyle, vascular risk factors, disease processes, ultimately leading to brain injury, which could be more neurodegeneration, but also vascular lesions together leading to cognitive decline. The disease processes clearly include proteinopathies like amyloid tau, alpha-synuclein, others that we can detect with fluid biomarkers, CSF, but increasingly also with blood. Vasculopathies that we can detect with imaging, but possibly with more direct measures, fluid biomarkers in the future, vascular dysfunction, other processes like neuroinflammation, oxidative stress, energy failure. So we will get a broad palette of markers. We will move from this syndromal diagnosis to an individual fingerprint, where this particular individual may have certain risk genes, may have certain risk factors, may have certain proteins in the brain and evidence of neuroinflammation, some evidence of CAA, have some vascular lesions, and in the next stage, this same individual may evolve to have additional proteinopathies, have additional brain injury. So it's a dynamic process where every individual moves along a disease pathway that may be composed of multiple components, and the treatment should move along. So in early stages, one may need to target risk factors. In later stages, one may need to target proteinopathies, but possibly also neuroinflammation. So not a single treatment for a single individual, but multiple treatments that move along and are adapted as the disease progresses. So this is how I hope the future will look, and I thank you for your attention, and I thank my team and our funders for their support. Thank you.
Thank Professor Biessels, wonderful lecture and insightful inspection. And now we have chance to open for the question from the floor. And the first question is from TCVGH, Dr. Li Weiru. He asked about which MRI biomarkers or methods do you suggest for VCI when only having 3T MRI?
Yeah. I think that at present, it's really the only validated biomarkers are the ones that show the lesions. And so white matter hypertensives, microbleeds, lacunes, and these do direct treatment. There is guidance on treatment, for example, from the American Heart Association, published in 2017, and also from the European Stroke Association, possibly also in Taiwan, where you get advice what you should do in terms of treatment when you find these different lesions. And this differs according to lesion type. So presently, no place for something more than 3-test MRI for diagnosis in clinical practice.
Okay. Is there any other questions from the floor? Professor Biessels, I have a question. I'm wondering if we redefine patients biologically, and how do we classify like a normal agent to how much degree of vascular burden to like AD that we can have the AD concept, or we will just call everyone with a different mixture of pathology.
Yeah.
Is there any targeted treatment for the vascular pathology right now? Thank you.
Yeah. So actually, it's with regard to your final question,
Yeah.
it's actually quite sad or sobering that we don't have this yet, because we have been saying all along that vascular comorbidity is so common in dementia,
Yes.
but the only thing that we do really is treat the risk factors. And I think that is really a pity, because vascular disease clearly has a biology of endothelial dysfunction, of basement membrane abnormalities, abnormalities in smooth muscle cells. So we should really move towards the biology of these diseases, and this is happening. So we see that there are leads from genetic studies that are tested in animal models and early clinical trials. And I expect that this more biology-driven approach to treatment of vascular disease will become common. But strangely enough, we also don't have this for atherosclerosis. Atherosclerosis, if people present with this disease, we treat all the risk factors, but we don't treat the disease process of atherosclerosis. And I think we should combine risk factor treatment with disease-modifying treatment.
Okay, thank you. And is there any other questions? Yeah, if you have question, you can type on the screen. Okay. Dr. Lee also asked another question. He asked, is there any potential fluid-based biomarker for VCI?
Yeah. So this is also a very important question. So the fluid-based biomarker that has been tested in VCI primarily is neurofilament light, which is a small protein which is released into the blood when there's neuronal injury. But the problem with the neurofilament light is that it's released almost by any type of neuronal injury. So also due to Alzheimer's disease, also due to head injury, also due to acute stroke. So it's really not specific to VCI. So it's really an injury marker. It could be useful in the future to monitor responses to treatment, for example, but it's not a very strong diagnostic marker. People are looking at GFAP, glial fibrillary acidic protein, and this also relates to VCI, but also relates to Alzheimer. We have been looking at in Utrecht at protein panels that relate to cerebral blood flow and to white matter hyperintensities. And here we get a signal of proteins that relate to endothelial function and to the basement membrane proteins, and that may get closer to something that is more specific to vascular, but this needs further validation. And this is really an area where I hope we see a lot of progress over the years to come, because I think that we should see an example in the Alzheimer field. their efforts to detect biomarkers have really driven their field forward. And clearly, it's easier if you have a disease that is already defined by proteins. A proteinopathy is an easier target because you know which protein you're looking for, and this is vasculopathies are generally not driven by single proteinopathy, so it's more difficult, but I think we can do it.
Okay, thank you. I noticed that you mentioned that some people have pathologies, but they have no dementia or cognitive deficit all their life. And you also mentioned that resilience is important post-stroke recovery. So do we need to treat someone when we find pathology without any like cognitive deficit?
Yeah, well, I think that we need to treat pathologies that predispose to bad outcomes. So this we know from the vascular field in general. So we treat risk factors and pathologies that are modifiable, that we know predispose to poor outcomes. So we treat the symptomatic carotid stenosis. We don't treat an asymptomatic carotid stenosis. We treat high blood pressure regardless if you're symptomatic or asymptomatic. So I think this should be the same for certain patterns of vascular injury, or also hopefully in the future amyloid. The diseases that predispose vulnerable people to poor clinical outcomes should be treated, but we are not in a position to do that yet because the treatments are expensive and potentially harmful. We don't know how to identify the right people in a reliable and efficient way. And I think in the future, the fluid biomarkers will be fundamental to this, and probably we will use them as a broad panel where we in one go look at all the different proteinopathies and vascular conditions. So it will not be a single test. I expect that in the future we have really a panel test that gives this fingerprint, but this needs a lot of change in our thinking, because currently we think in single diagnosis, single etiologies. Also needs another language for the patients, because I mean, how do you explain a fingerprint in proteins in diagnostic terms to a patient? So there are challenges ahead, but I think it's exciting times, and I'm quite sure that the field will be quite different 10 years from now.
Thank you. And Dr. Wang Shujun from Taipei Veteran General Hospital, he asked, is there any basic studies focusing on the interaction between proteinopathy and vascular factors in AD, or just add-on effect?
Yeah. We have been studying some of that ourselves. If you look, it really depends on the disease stage. So people who have not yet developed dementia, there the interaction between vascular lesions and amyloid load in terms of prognosis is more clear. So in people with MCI or people with subjective cognitive complaints, if they are amyloid positive and they have wide matter hyperintensities, cognitive decline is going to be faster. In people who have already moved to dementia, if they have Alzheimer's pathology, the vascular lesions do not appear to have such important prognostic weight. But I guess if the ATN framework is modified according to the suggestions that are now being done, we will get much more of these kind of data and get a much more precise estimate when the prognostic value of vascular comorbidity is relevant and when it's less relevant.
Okay, is there any other questions on the floor? Or, okay, if there's any other question, due to time limitation, I thank Professor Biessels for this wonderful talk, and we hope that we can see you in person in Taiwan soon. Thank you.
I hope so too. It has been a pleasure on previous occasions, so thank you very much.
Thank you, and have a nice day.
Bye-bye.
Bye.